Hi, I'm Natalie DiPietro Mager, and in this episode of Scripted for Her, I'm talking with Paul Weidle. Paul holds degrees in both pharmacy and public health, and he recently retired from the U.S. Public Health Service after over 28 years working in the Centers for Disease Control and Prevention. He spent most of his career in the Division of HIV Prevention, working both domestically and internationally. From 2019 to 2025, he was a senior advisor for HIV prevention and treatment and played a key role in CDC's response to the Ending the HIV Epidemic in the U.S. initiative. Paul has published more than 100 peer-reviewed articles on HIV and other infectious diseases, and prior to his work at CDC, he served for a decade as a clinical pharmacist at the University of Maryland Medical System, specializing in adult medicine and infectious disease HIV medicine. So thank you so much, Paul, for being here with me today.
Well, thank you, Natalie, for inviting me. I'm looking forward to the presentation.
Yeah, me too. So, March 10th is National Women and Girls HIV/AIDS Awareness Day. And this day annually gives us an opportunity to shed light on the impact of HIV and AIDS on women and girls and to show support for those who are at risk of and living with HIV. So, given his deep expertise, I've invited Paul to share some information regarding the current burden of HIV infection among women in the US, prevention options for women, and importantly, opportunities for pharmacists to expand those options. So, Paul, let's get started with reviewing the incidence and prevalence of HIV infection among women in the US and any subgroups who are disproportionately affected.
Sure. So, in 2023, an estimated 1.1 million people had HIV in the United States, of whom approximately 23% were women. The Ending the HIV Epidemic initiative in the U.S. was announced by President Trump during the 2019 State of the Union address and was then launched by Health and Human Services with the goal to decrease HIV incidence by 75% in 5 years, which would be 2025, and 90% in 10 years, by 2030, from a baseline of about 37,000 new HIV infections per year. So just note, incidence is new infections that are estimated to have occurred in a given year, and these data are estimated from diagnoses from subsequent years. So diagnoses, when a person is diagnosed, they might be diagnosed in February of 2026, but they were likely acquired the infection before 2026. And so there's an estimate for how long prior that infection may have occurred. So diagnoses and incidence generally track in a similar pattern, but they're not the same thing. So the federal agencies, CDC, HRSA, NIH, the Substance Abuse Mental Health Services Administration, and the Indian Health Service all have a role. But importantly, the effort is an all-of-society approach with important contributions from the business, philanthropic, and professional sectors. Pharmacy plays an important role in EHE through professional associations and through individual efforts at the pharmacy level. So all the data I'm presenting, of course, are all publicly available data. There's no inside CDC information here. These are all publicly available. And the most recent year for which HIV incidence has been estimated was 2022, and it showed a reduction of approximately 12% in incidence to about 31,800 new infections, of which about 5,900 or 19% were among women. Now, this is remarkably consistent over the past years, with women accounting for approximately 20% of all new HIV infections each year. In 2022, Black African American females accounted for approximately 50% of new HIV diagnoses among women. White females accounted for approximately 25%, and Hispanic Latino females accounted for approximately 20%, with other race and ethnic groups accounting for the remainder. The transmission category of HIV among women was heterosexual sex for 83% and injection drug use for the remainder.
And so, just all of those statistics really underscore the importance of HIV testing and treatment. So, how can pharmacists really play a role here?
Yeah, HIV testing allows a person to know their status, whether they're positive or negative, and using a whole person approach to care is a cornerstone of HIV prevention and care. So as frontline providers, pharmacists are well positioned to provide that care and advance the capacity to control HIV in the United States. So people who receive a negative HIV test can be offered powerful tools that prevent HIV, including pre-exposure prophylaxis, and of course, information about HIV prevention, including access to condoms, sexual health services, and harm reduction services if needed. If a person tests positive for HIV, even on a single rapid test, they should be referred to a care provider for confirmatory testing and to begin HIV treatment as soon as possible. So the goal for treatment is first to improve the health of the person with HIV, but also has the benefit of reducing transmissibility to essentially zero if the person achieves and sustains an undetectable viral load. Current HIV treatment is extremely effective and robust at reducing viral load. It can be given as a once daily treatment combination tablet that is very well tolerated. And there are approximately 30 HIV medications on the market, so any hint of intolerability or potential resistance can be overcome in essentially all cases. So pharmacists can help support immediate access to antiretroviral therapy and provide support for adherence and timely refill of medications. Importantly, pharmacists monitor for lapses in refill pickups and can proactively reach out to the patient and to the provider if necessary to ensure that a person stays on HIV treatment. That is, take an active role to make sure the patient stays on treatment and step up your action to contact the provider if you're unsuccessful in locating the patient or convincing the patient to continue treatment.
Mm. Absolutely. Those are all really important ways that pharmacists can provide essential support to patients with HIV or at risk for HIV. And when caring for women specifically, another consideration we need to add is whether the patient is pregnant. So, what do pharmacists need to know about HIV in pregnancy?
Sure. Antiretroviral treatment can effectively stop mother to child transmission of HIV in pregnancy and during childbirth. So in 2022, CDC published a framework for elimination of perinatal transmission of HIV in the United States, recognizing that there were plenty of interventions to maximally reduce the risk of perinatal transmission, and they were widely available. The cornerstone of those were HIV testing amongst pregnant women. So the framework emphasized the roles of all sectors of healthcare and public health, particularly the importance of clinical care of persons of reproductive potential with HIV, and then, of course, perinatal HIV services coordinated by public health and clinical providers. So the number of U.S.-born infants with perinatally acquired HIV decreased from about 74 in 2010 to 32 in 2019, and that marked the year that perinatal HIV elimination goals were first achieved. More recently, in 2023, there were only 23 perinatally acquired HIV infections among babies born in the United States. So a terrific success.
Wow. I mean, absolutely. If you just pause and think about that for a moment, that just really is a remarkable advancement. So, it's so encouraging to see prevention in that realm. And let's just keep talking about prevention. So let's talk specifically about prevention options for women, and starting with pre-exposure prophylaxis or PrEP. So, what are the components here that pharmacists need to be aware of?
So HIV pre-exposure prophylaxis or PrEP is part of a comprehensive HIV prevention plan that includes discussing how to take PrEP as prescribed, proper condom use, screening for other sexually transmitted infections, and other risk reduction methods. That is, it's more than just the medicine. For women, there are three drug regimens approved for PrEP. So the first is the daily oral PrEP with emtricitabine, tenofovir disoproxil fumarate, or FTC-TDF, and brand name Truvada. So you may have heard of event-driven PrEP, which is sometimes called 211, which has been studied among men who have sex with men, where a person takes 2 pills before they have sex, and then 1 pill 24 hours later and 24 hours after that. So it's for people who can anticipate when they'll have sexual contact. So this has not been studied in women and is not recommended for them. The sister product to emtricitabine, the sister product to Truvada is emtricitabine tenofovir alafenamide, or brand name Descovy. That's not been studied in women and is not indicated for women. And unfortunately, one consequence of it not being studied in women led to commercials on TV that say Descovy is not for women, which was interpreted by some that PrEP is not for women, which of course is not true. But it's one thing that you have to overcome. If somebody says, "No, I hear PrEP is not for women," that's often the reason that might be something like that is the reason that comes up.
Mm.
So cabotegravir, also called Apretude, is an IM injection that's initiated as a first injection on day 0 and then followed by a second injection 1 month later and then every 2 months thereafter. So this has been adequately studied in women and has an indication for women. The IM injection is administered by a healthcare provider, typically in a clinic, but there are some examples of visiting nurses administering it outside the clinic. So the challenge and interesting thing with something like cabotegravir is that there are frequent clinical appointments, and there's a need to have the medication on hand just in time. So this actually removes the burden of refills from the pharmacy to the clinic, but the pharmacist can still play an important role in assuring the medication is available when a person comes in. So then more recently, just last year, another product, lenacapavir, brand name Yeztugo, was approved by FDA for PrEP, and it's administered as a subcutaneous injections every 6 months. So on day one of initiation, the patient takes 2 tablets by mouth, in addition to the subcutaneous injection, which is actually 2 injections, typically given in the abdomen, 4 inches apart. And on day two, takes 2 more tablets by mouth. Then the patient gets 2 subcutaneous injections every 6 months, so that they only have to come in every 6 months for the injections. So in terms of using these drugs in women who may become pregnant or are pregnant, the first product, FTC TDF or Truvada, is considered generally safe. For both injectable forms of PrEP, there are more limited data in pregnancy, but either may be used with shared decision making with the provider and the patient agree. Now, note, of course, if a woman becomes pregnant while on injectable PrEP, you can't stop it right away. It's already been injected and it takes time for it to wash out. It takes a long time for it to wash out. So the decision then between the provider and the pregnant woman would be whether to continue injectable PrEP or perhaps switch to Truvada at some point instead of continuing the injections. But again, it's a shared decision making between the provider and the woman. For breastfeeding women, oral PrEP with FTC TDF is generally considered safe for the infant. Use of either form of injectable PrEP while breastfeeding should be considered again through shared decision making between the patient and provider, including options for other forms of infant feeding via formula.
Mhm. Well, thank you. That was a really excellent overview of PrEP. So now let's move on to the post-exposure prophylaxis or PEP. Can you walk us through those guidelines for women who have had a non-occupational exposure to HIV?
Sure. The non-occupational HIV post-exposure prophylaxis or NPEP guidelines were updated in 2025. The most recent update before that was 2016. So there are a few changes. A lot of the things stay the same. NPEP for HIV is recommended when a non-occupational, for instance, a sexual, needle, or other exposure to non-intact skin or mucous membranes that presents a substantial risk for HIV transmission has occurred. And the source has HIV without sustained viral suppression, or their viral suppression information is not known. So NPEP is recommended when an exposure has occurred within the past 72 hours that presents a substantial risk for HIV transmission, and that hasn't changed. But importantly, we should initiate NPEP as soon as possible once the decision is made to use it, but no later than 72 hours after exposure. A case-by-case determination is required when an exposure has occurred within the past 72 hours that presents a substantial risk for HIV, but it's not known whether the source have HIV. Examples of that could be sexual assault and a woman ending up at the emergency room trying to decide what to do next. So the things that have to be done before starting PrEP, complete clinical assessment, including assessing for medical comorbidities. I said before prescribing NPEP, include assessing for medical comorbidities, current medications, and allergies. And the pharmacist can do a lot of this stuff quickly in the pharmacy if needed. The recommended NPEP course is 28 days, and that hasn't changed. And the preferred regimen for adults and adolescents without contraindications, that's changed. So now the preferred regimens are either bictegravir, emtricitabine, tenofovir, alafenamide, which is a combination tablet, Biktarvy, or to use dolutegravir plus one of the forms of tenofovir plus either emtricitabine or lamivudine. That would be the other first-line recommendation. And the selection of the regimen should be individualized based on comorbid conditions, of course. An example, if a person has renal or hepatic dysfunction, pregnancy, drug interaction potential with concurrent medications, previous exposure to ARV regimens, for instance, if the person who's going to take NPEP had previously been on PrEP. The source's history, of course, and then regimen and factors that might influence continuation of treatment. So pharmacists can play an important role by having NPEP medications available when needed, including potentially in starter packs to get a person started on NPEP while awaiting results of HIV testing from the source person if applicable. NPEP can always be stopped if it's determined that the source, did not have HIV, and the provider and the patient just decide to stop it. Now, importantly for women, pregnancy and breastfeeding are not contraindications for NPEP. Pregnant or breastfeeding women should have rapid access to NPEP when indicated. But because of the additional considerations regarding fetal and infant safety, expert consultation might be beneficial when NPEP is prescribed to women who are pregnant or breastfeeding. A pregnancy test should be performed in women of childbearing potential at the initial evaluation for NPEP. And for women who are pregnant, consider available pregnancy safety and outcome data, known adverse events, and pharmacokinetic properties of antiretroviral medication. Now, it's essentially impossible for most of us working in a pharmacy to keep up with all those details. So fortunately, the National Clinician Consultation Center, also referred to as NCCC, provides tailored clinical consultation for U.S. healthcare professionals to questions about managing HIV/AIDS, perinatal HIV, pre- and post-exposure prophylaxis, bloodborne pathogen exposures, and substance use disorders. So their website is ncccc.ucsf, they're at University of California, San Francisco.edu. They're available by phone for consultation when needed.
Yes, well, again, thank you for such a great overview of the NPEP options as well. So, unfortunately, we don't have too much time left remaining. So, I have one last question for you, and it actually has two parts. So, the first part is, how can pharmacists get more involved in providing PrEP and NPEP? And you just mentioned the NCCC, but what are some other good resources that you're aware of that pharmacists can use if they want to learn more and get more involved?
Sure, pharmacists' involvement in PrEP and NPEP care and delivery includes initiation of antivirals through standing orders or collaborative practice agreements with physicians, including through legislation in a growing number of states. Pharmacists are critical for the timely dispensing of medications for post-exposure prophylaxis against HIV infection in coordination with HIV prevention, public health programs, and clinicians. So the National Association of State and Territorial AIDS Directors have published a number of useful resources for pharmacist involvement in PrEP and NPEP care delivery. Pharmacists in many states can start PrEP or NPEP under collaborative practice agreements with physicians or through statewide standing orders. So these mechanisms allow pharmacists to provide frontline care. Some of the challenges with administering PrEP or NPEP in this manner includes the training requirements, which can vary by state. They essentially all require pharmacists to have taken some sort of training before they can use the standing order collaborative practice agreement. And then, of course, it takes time to establish the collaborative practice agreements if needed. And of course, the time to integrate will be typically an occasional event-driven intervention. In the case of NPEP, right? Somebody just shows up and says, I need to start NPEP, into a busy workplace, often without adequate reimbursement. In addition, some of the standing statewide orders are very prescriptive in what the pharmacist can and must do. So in some ways, they have the nice checklist of all the things that need to be checked off and to walk through what needs to be done before the person starts. But sometimes it's a lot of work, right? And so who has time for all this, right? And that's what you have to figure out, how to get that in place. So it's typically best when the law authorizes the implementation of a standing order that is delegated to the Department of Health or someone else to draft, and allows for editing over time so that they can update it as new products come out and new information comes out. Sometimes they are overly prescriptive in the past, actually naming the product which could be used. But a better way is when they just say any product approved by the FDA for PrEP can be included. So in terms of training, the American Pharmacists Association has developed a certificate training program for pharmacy-based HIV prevention services with the intention and hope that the training will be sufficient for any state. And that's readily available for a fee through the American Pharmacists Association.
Well, thank you. These are all great insights, and we're going to have links to those resources that you mentioned posted to the Drug Topics webpage along with this podcast. So Truly, Paul, I just cannot thank you enough for your time to be here today, sharing all of your expertise and providing really such key information regarding HIV prevention treatment for women in the United States. So thank you.
Thank you, Natalie.